Good afternoon. Welcome back. It looks like we've got some stragglers, and I can understand that. First time we've been able to have lunch with some of our peers we haven't seen in a long time, which was a very nice thing. I hope you had time to enjoy that, talk with some folks you haven't seen in a while. I'm Chad Shear. I'm Senior Vice President for Policy and Program at UHF. And I just want to reiterate Tony's thanks earlier today to the entire team at UHF, especially my Medicaid Institute team, and to the generous support of our donors that have made this event possible today. We heard this morning about the waiver generally and the role of regional planning, and not surprisingly, the issue of social needs as we focus on health equity came up a lot already, and it's rightfully a focus across all aspects of the proposed waiver amendment. This afternoon, what we hope to do is dig in a little bit more on the concept of social needs networks specifically, and get some insight from a couple of organizations named in the waiver amendment proposal that have some real on-the-ground experience to share. They're hoping to share some of the opportunities and challenges associated with bringing social service agencies together in partnership with the healthcare system. So today I'm honored to be joined by Laurie Andrade from the Health and Welfare Council of Long Island, where she is the COO and directs the Health Equity Alliance of Long Island, and Christopher Joseph, who's the Executive Director of sorry, I wrote it down wrong. Right. Engage Well IPA. It just says Well IPA here on my sheet. That's horrible. Their full bios, which I obviously didn't look at, are on the website and in the Zoom event, so I won't belabor the introductions. We do call these conversations often after lunch fireside chats, but I don't think that's probably the appropriate mindset to be in today. So given the weather outside, maybe we'll imagine this conversation on the patio or by the pool as opposed to in front of a fire. I'll put visions of umbrella-adorned drinks in our head, and we'll jump right in. So let's start with just each of you taking a minute or two to tell us about your organization, your network. How are you currently addressing social needs and delivering social services, and how at the present time is that coordinated with healthcare delivery? Laurie, we'll start with you.
Sure, thank you. I'm Laurie Andrade, the COO of the Health and Welfare Council of Long Island. I'm happy to be here today to discuss our work with you. Health and Welfare Council of Long Island is the umbrella organization of health and human service agencies. We have a network of about 200 agencies on Long Island, and we've been around since 1965 doing sector-wide planning. We convene and lead HEALI, the Health Equity Alliance of Long Island, which is a coalition that was built out of the DSRIP CBO planning grant, and it's a coalition of about almost 100 agencies that address the social determinants of health, the full range of services, from Elmont to Montauk on Long Island, deep in communities. I just want to give just a second just to give a slight little background about Long Island, because I think it's very important to contextualizing the way in which HEALI has developed its work. Oftentimes people think about Long Island, especially this time of year, as the Hamptons and the Gold Coast, but in actuality that is not what Long Island is. We have very deep segregated communities. We are one of the most segregated communities in the nation, and we have very deep pockets of poverty. And a couple of other pieces that are really critical to the way social care is delivered on Long Island. We have no centralized government. We have 2 counties, which each with its own departments of social service, departments of health, and departments of mental health, as well as 2 cities, 95 13 towns, 95 incorporated villages, and 124 school districts. So social care, as we heard in the panel this morning about trying to be integrated in interoperability in systems, is challenging in a place like Long Island, where there isn't that centralized government to really help lead in the formation of a social care system and interoperability. And just one other point is really important is, oftentimes as plans are put into place, they're urban environments, particularly for a place like Long Island. New York City is often overshadowing the needs for Long Island. And people think, well, you could just kind of retrofit what you do in New York City and it'll be fine for Long Island, and in terms of the provision of social care. And that's just not the way that it works for Long Island. It really needs to be looking at specific solutions and how we provide social care.
Great, thanks. Chris?
Good afternoon, everyone. I'm Chris Joseph. Thank you to UHF for the invite. I am the executive director of the Engage Well IPA. For those of you who don't know, IPA is just a fancy word for network or consortium. It stands for Independent Provider Association, but I often get that question, are you a beer company? And I said, no, we're not. So yeah, I've been with the IPA for about 3.5 years. The IPA itself has only been around for about 5 years. So as a network itself is fairly young. We're a healthcare startup, currently 15 members strong. But the individual members of the Engage Well IPA have been collaborating informally and formally for decades. Many of the organizations got their start at the height of the HIV epidemic in New York City, recognizing that people were dying of HIV, AIDS, and ignored essentially by the healthcare system. And so at the core of a lot of the work that we do is this kind of grassroots advocacy for people with HIV and substance use disorder. I came in about 1 year into the IPA, and we were formed to, navigate value-based payment and Medicaid reform for this network of providers. So we are a separate business, and I bring that up because it is a business. We're not just coming together and collaborating because it's fun and something we should do. We're trying to come up with a model of care and a business strategy that sustains the IPA and our ability to do this work. It's been very exciting to be a part of this growing organization at a time when Medicaid is constantly changing. We have, like I said, 15 member owners of the Engage Well IPA, or participating providers in the IPA. Some are very small, grassroots syringe exchange programs, operating very much boots on the ground in the community, meeting people where they are using substances or where they may be unhoused and trying to stabilize their services, up to and including multi-service organizations, federally qualified health centers, housing facilities, thousands of units. We have behavioral health services, both outpatient mental health and outpatient substance use services. We have a slew of social determinants of health, legal, food, housing, education, employment services. So we really have, when you think about an integrated care model, the IPA has all the ingredients, but is really targeted to reaching some of the most complex members. We are oftentimes trying to work with managed care to target that top 5 or 10% of spending. And so, it really is a challenge. It's exciting, and I'm excited to dig deeper into the work that we're doing.
We heard a lot this morning about the role of trust in developing networks like this. Can you talk about kind of what your process is to kind of continuously foster trust? How long does it take to build trust? What are some of the challenges to creating meaningful collaboration in your different types of networks? And Kristen, why don't you start?
Yeah, I mean, that's, as the executive director, and I have a small team that supports me. Somewhere in the room, it's good to see you. We're always thinking about how can we develop models of care, how can we develop policy statements, how can we develop work that will benefit everyone. And that is really hard to do, especially in a diverse network. Oftentimes, an RFA will come across the table and like, who's going to, help us apply for this? But it's, it's really focused on housing, and so who do we take that to? Or maybe it's a medical model, and so now our FQHCs are at the front, and we oftentimes see that some of our harm reduction providers don't get the attention we think that they deserve, or some of the adult education or employment, these things that they've built businesses around. So it's always about how can we be sure that we do bring people together constantly. We've cut back on some of those meetings during COVID, but monthly meetings, and so we're always trying to make sure that that the conversations are circled around our vision, our mission, and what is aligned with the IPA and what really is a provider level initiative. And that is always a fine line for us, because I don't want to become a competitor for my providers, right? And I don't want to be competing against them. So, we are constantly thinking about, is this the right opportunity for the IPA to further our mission and our vision? And then who are the right partners? We're not going to find a single model that fits all 15 providers because of the diversity of the network, but making sure we equalize the opportunity, and you're going to take the lead on this one, or you're going to take the lead on this one. And that has been our approach, to make sure that everyone has an opportunity to prove that the value of their work.
Yeah, and we'll come back to some of that balance question a little bit later.
I think the Health and Welfare Council of Long Island was unique when the CBO planning grant came out with DSRIP because this is the work that we do as the umbrella organization. So we've been running coalitions for 75 years where the trust is so ingrained in building trust with our agencies. And when this opportunity came to be, we brought together 6 executives that were represented different social determinants of health to form a steering committee or governance body. So it wasn't the Health and Welfare Council of Long Island driving decision making and the work. It was the steering committee with Health and Welfare Council of Long Island really being the administrative backbone for that. And so when we brought agencies, the steering committee very quickly determined that we were going to use this as an opportunity to focus on health equity, the long-standing disparities for Long Island, as well as the issues related to what I was speaking about before in terms of not having centralized government, thus not having centralized infrastructure. So we were thinking about using this for something, a really big idea for the region. And so we kicked off with a health equity summit to really lay that groundwork that this was going to be about health equity, and then convened 80 organizations shortly after to talk about what would be the mission and the vision of the coalition of HEALY. And it was really quite astonishing that when we brought this group together, that they very quickly left their own agency's agenda and mission at the door, which doesn't always happen, but it really happened quickly in this situation. And I don't know if it's because Health and Welfare Council of Long Island does this trust work, or if it's because we're just so in need of infrastructure reform and a social care infrastructure that the need outweighed any one organization's needs. But we came together, and that's really been the work that we've been doing since then, is to continue and have the monthly meetings where we bring new information to people, as well as the steering committee continues to meet monthly, drafting the public comments for the 1115 waiver, bringing those comments to the coalition. It's process to do that, and it's time and effort to do that, but it's really been able to sustain the work moving forward and allow us to really build that trust that allows us to look at when we're engaging with agencies to onboard into a referral platform, what are the processes that need to be in place? Because there's trust there, and we're able to really take that lead with the agencies and work through a lot of the difficulties that kind of we heard about this morning also, and to be able to move forward.
Yeah, one thing I want to add, and I should have made this clear in the introduction, the IPA formed out of 2 existing advocacy organizations. So luckily, a lot of that alignment and trust and relationship building happened prior to the IPA being developed. One was the IDUHA, Injection Drug User Health Alliance, and iHealth, both advocacy organizations with shared membership amongst the 2. There were some in one and some in the other, and like a bit of a Venn diagram. So a lot of that work had been done for years prior to the IPA coming together. And again, this was a business decision. How can we, some of our smaller organizations really need support with navigating Medicaid reform, building the infrastructure, putting the quality measures and steps in place. And so can we actually develop a business out of this? So a lot of that for me had been done, but that was decades of work. And so I just want to give credit where credit is due. This was decades of relationship building. And when you start bringing in the conversation around a business, it does change the conversation a little bit of how are we going to generate revenue, how are we going to be sustainable, who's responsible. And the way our business is set up is, doesn't matter the size of your organization, decision-making rights are shared. It's in our operating agreement that if you're a small organization or a large organization, you get the same number of votes, you're paying the same member dues, we're a membership organization. So that also just some of the basic operating agreement is important. To note that it's in the groundwork of how the IPA is developed.
Yeah, and I think that's a good reminder, like all of this work takes a lot of time and effort. It doesn't happen overnight, and as we think about the waiver, thinking about what it's going to take to do this in some places where that infrastructure doesn't exist already. Pulling on another thread that came up this morning, kind of both of your networks really do focus on the specific needs of the clients being served and putting their needs at the middle of the collaboration that you're doing. How do you kind of build that focus into your systems, your collaboration, the workflows, the continuous quality improvement? And how do you think about that juxtaposed to kind of the other pressures on the collaborative, whether that be from funders and reporting requirements and people really focused on value and ROI? How do you deal with that balance?
For Healy, we're really focused on building out a strong, interconnected technology platform, and really looking at it, from the breadth of what it is able to do. I mean, of course, there's going to be project-based work that is going to be able to tap into that and look at specific populations, targeted populations, and create unique projects for that could be ready for value-based payment. But if you don't have the broader system in place, and really what we heard about this morning also, again, is it's about connecting at the agency level and being able to do closed-loop referrals and being able to share information so that clients in an area like Long Island, where we don't have public transportation, don't have to go from agency to agency to agency retelling their story, are able to be referred and referred carefully. And Health and Welfare Council is looking to build out the capacity as a coordination center to ensure that those referrals are tracked carefully and closed. But it's also looking bigger at the public facing, right? How do individuals, and we learned this in COVID, people who were experiencing hunger for the very first time in their lives, in their home, isolated, or folks on Long Island who maybe live on the East End, where it's much more rural, and we have undocumented individuals who might not be connected to any kind of care or healthcare system at this time, but yet they're experiencing hunger. So how do they connect to services and resources and know that what's available, and that connection to a 211 system, that connection to a public-facing resource directory is really critical as part of a larger system. So I think it's making sure that we're not just narrowly focused in one area, but we're building out a system that is going to be able to ultimately, be interoperable with other systems. When we first started Healy, we brought in 211 San Diego. We brought in Laura, actually, to talk about her interoperability system. And it was like, wow, community information exchange, big idea. That's what we want to go to. But, it's not overnight. It's step by step to get there. But that's really the vision that we have, is that, you have to have that the capacity to serve all people where they are.
Right. So the network started because people in the 80s were literally dying on the street or not dying with dignity, and so there has always been a kind of frontline advocacy component to the work we do. And to this day, I mean, a lot of the peer-based models in the state that are recognized as best practice at the state, CHWs, peer navigators, patient navigators, however you want to call them, our network really has led that way for people with HIV for many, many years. And, our networks pride ourselves with hiring people from the community who look like the community, who have come out the other end and say it's possible. And so that remains a factor in the work that we do, and we continue to try to double down on that and try to come up with models. So I think the frontline workers that the IPA convenes when we have a project, so we're launching a telehealth platform, the frontline staff is constantly reminding us that's not going to work for the client. That's not going to work for the client. What about people without a smartphone? And so we really do rely on a learning collaborative approach, bringing in, and that's in addition to our regular compliance meetings and the board meetings, and we do try to bring our frontline workers together. I think the other thing that the IPA is able to add when we do this work is, you go do what you do well, serve your patient. Let's put a system in place where we will be responsible for the reporting to the funder for you. Yes, you're going to have to send some basic data to us, but let us compile that report. You spend your time treating clients in the evidence-based practices that you're trained to do, rather than worried about some of that data infrastructure and basic stuff. So, it has been a fine line. We're not service providers. I mean, I'm a social worker by training, and so I can bring that in, but that, we do need to listen to the frontline workers, and my colleague Cheyenne and I do that frequently. We're interviewing. We have a consulting firm too that helps us interview, and it's similar to what we heard earlier, that you have to listen, and as things change, making sure the clients, whatever product or program or software you're going to buy is really at the core addressing the basic needs of the client.
So you just mentioned peers. There's mention of CHWs earlier this morning. One of the potential benefits of a CBO network might be thinking about opportunities for facilitating shared human resources that could be used by multiple organizations in a network, especially in the CHW or peer space. How do you think about the balance of, where should those services live? How can they best meet the needs of the network and the individual members without blowing up your networks?
If I can jump
Sure.
in here, because I'm really excited about this project. But with the New York Health Foundation, it just gave us a great award to develop a small team of CHWs. And for the first time, these CHWs are going to be shared across 6 agencies, which is really exciting. It's one of the ways an IPA can add value. They will be. We have to operationalize it still, but we are excited that we'll have 4 or 5 CHWs or peers that, using a closed loop referral platform. We're partnering with Unite Us to do that work. Say, I need a client who needs help setting up the smartphone, or I need a client who. I have a client who needs support getting to the doctor, and they can make a request, and we will be able to deploy a CHW. We've got some learning to do. Is how do we actually ensure that that CHW team is being equally utilized, and how are we measuring that standardized workflows are happening across 5 different agencies? So we have a lot to figure out, but we are excited to show that economies of scale and shared staffing might be an interesting solution, and how do we, how do they talk about which agency they're coming from? We have a lot to figure out, but I think that people are recognizing that it doesn't make sense necessarily for every single organization out there to have their own CHWs. If that could be a solution. That's costly, and there's a lot of training that has to happen, but how can we leverage the shared staffing? I'm really excited about that component of this project, which is really about digital health and training people, people who are not used to using digital health to interact with their healthcare providers to do that. So we're excited to see how, and we'll be happy to report out on that.
I think for Healy at this time, we're really excited about the emphasis on CHWs in the 1115 waiver and the reinforcement of that this morning. We know that they are critical to restoring trust with healthcare and with public health right now. CBOs themselves have strong trusted relationship in social care and community, and CHWs can play that role in really connecting community and social care and healthcare and building that trust across. And Long Island doesn't have a coordinated or integrated, community health worker workforce at this time. We have community health workers kind of here and there, but nothing that is cohesive in terms of what they're doing and kind of what's going on across. So Health and Welfare Council of Long Island is leading for Healy an assessment of the community health worker landscape on Long Island. We've been working closely with Public Health Solutions, who has real expertise in this area, and looking to see, what fits under the umbrella of community health workers. Who are they? Where are they working? Where can we look for some commonality so that there can be possibilities of looking at different types of models, because there's those commonalities, without hopefully losing the unique aspects of community health workers, because they are such a unique piece of the team in and serving people. So from that, we're going to create a roadmap for which we are hoping to really develop the CHW workforce on Long Island, and to start to look at what might be some of the possibilities in terms of staffing and utilizing CHWs.
Yeah, and I would add that one of the reasons we're taking this shared staffing approach is, when you decide to implement a peer-based workforce or a CHW workforce with lived experience, as a social worker, I remember learning about countertransference and transference, and things are going to come up that may impact that CHW or that peer worker's ability to do their work, and it takes a special buy-in from the agency, from the leadership. It takes special supervision. And does it make sense to carve out 0.25% of supervisors across 15 agencies? Maybe not. Maybe it makes sense to have 1 or 2 full-time supervisors that are supporting a team of of CHW. So again, it's not just economies of scale. It's about how can we how do we take the expertise that it requires to oversee a team like this? And one agency may really want to have CHWs at their agency, but doesn't have the time or the expense to pay to a supervisor, which again, it takes the sweet spot. And you bring up a good point there around not over too many certifications or making the position too academic. We have seen Medicaid take that approach, right? You have to have a certified peer specialist to bill Medicaid for that, and we understand that from a quality perspective, you need that sometimes. But if you start to over academics or too many certifications, you kind of pull the flavor of what it means to be a peer out of and you become inserting mistrust into a peer-based workforce that's supposed to help broach that mistrust.
Yeah. So folks in the audience, get thinking about your questions. I'm going to pose one question each to these guys and then move to audience questions. So get your questions thinking, get ready to get up to the mics. Laurie, you've been really successful kind of funding the current infrastructure, mostly through grant dollars, but obviously one of the goals of the waiver is to think about what does long-term sustainability look like. And we know even with the waiver, there's potential long-term sustainability risks. How are you thinking about sustainability in this changing landscape with the waiver proposal as potentially part of that? And what are some of those ongoing kind of threats to sustainability that you're worried about in Long Island?
I think in terms of sustainability, part of it is thinking broadly, as in terms of building out the system, in terms of technology, or the human system in terms of the community health workers. It's not looking at project-based work, but looking broadly so that there is the opportunity for interoperability moving forward. So it's looking at being able to look at different funding streams, but there does need to be, and I was, excited this morning to hear that there is going to be that investment in social determinants of health networks, which are so vital and have the experience in building out these types of systems across the state right now and have that expertise. And any type of upfront investment in being able to build out the capacity to do this work is really going to be critical, so that social determinants of health networks and Health and Welfare Council leading Healy's is able to build out the capacity to onboard folks, to make sure that there's coordination centers to do all of that type of work. But I do believe it's the broader the system is going to help ensure the sustainability of the system. If it's too narrow in focus, then it's not going to be able to be sustained.
Speaking of narrow and focused and the realities of current sustainability, Chris, you've obviously just been through kind of a contracting process. Can you talk a little bit about kind of obviously the view that managed care is going to cover a lot of this in the long term, the realities of what it was like to go through a managed care contracting process for you and other opportunities you see on the horizon to...
Yeah, I'm happy to. So in addition to being an IPA formed by a network of community-based organizations, in 2018, we received designation as a behavioral health care collaborative, a Bhcc, which I think many of you have heard about. If not, it's another network of behavioral health care providers. Some of those Bhccs are really focused on outpatient mental health. Some are really focused on outpatient substance use treatment, keeping people out of the hospital, all the value-based goals. Our IPA Bhcc is a little bit of a horse of a different color in that we do have more than just mental health, outpatient, substance use, and harm reduction services. We have all these other things. And so, we do have our first value-based payment contract with our partners at Medicare, which is really exciting. It's a relatively small contract when you talk about value-based payment, but, it was not an easy process by any means. We've been talking about this value-based payment contract for a couple of years, and we finally got the quality measures and which SDOH services we were going to focus on and how we were going to pay for those and how we were going to make that money back and what has, what shows ROI, but really what's the client needing at the end of the day. And then it went to the state, and the state took their time. It's a long process. It's by no means, and it just takes time. And talk about trust building between an MCO and a CBO network. That is another whole part of the conversation, because we're all trying to do the same thing, is reduce healthcare spending. So we just executed that in May, and so we're right at the start of implementation for that. But it's not going to sustain an IPA with just one contract. So we are relying on other grant funding to do this, and we're trying to replicate this model and bring it to other MCOs, and each MCO has their own metrics that or quality measures that they're focused on, and it may or may not align with the model of care that you've just spent 3 years designing. So, you have to be flexible, you have to serve, I've had to serve as an advocate for the network where, sorry, MCO, that might not fit the direction we're going right now, even though we want to partner with you. So it's a fine line for us to, what's going to sustain our business, what's going to improve care, but what can my network reasonably do right now? There are other alternative payment methodologies, and it's one of the questions I wanted to ask this morning. It's value-based payment contracts, level 1, level 2, and all that. That's just one form of alternative payment methodologies, and there are in lieu of service applications out there that I've begun to learn more about. And one of the projects that we're trying to, medically tailored meals is one of the SUH benefits we're offering in the level 2 arrangement that we have. So there's no limitations on who it can be offered to. Like the providers just dictate who is eligible for that. But if you look at the state's in lieu of service application, there's very clear criteria about who is eligible for a medically tailored meal. And medically tailored meals are costly from an SDOH perspective, and like per meal, or and that's just more money you have to make back, or at the end of the contract period. So we're saying, can we use food box as a lower cost intervention? Can we prove that has an impact on total cost of care spending? And is there a future of in lieu of service applications for that? And then there are enhanced fee rates. There are all types of alternative payment methodologies that, if I had feedback for the VBP roadmap, is to explain some of that more, because its focus is always on total cost of care and reducing cost of care. But there are other ways to participate in VBP that's not risky and not risk-bearing, and it really is an incentive-based model. And I'm learning more about it. I'm sure many community-based organizations would like to know more about what an alternative payment methodology looks like. And so if there's any feedback I have, is to maybe make that public or share those model templates or successful projects, because you start talking about risk-bearing contracts, it can become scary for some CBOs to want to be a part of.
Great. With that, we'll open it up to questions. Folks have questions? Any from online? And I'll keep asking if you don't, but that's no fun. None from I'll just sit here and continue to talk to you. I have no problem doing that. So we all took different and very important lessons away from DISRIP. I think, but one of the overarching lessons was that CBOs were both under-supported and underutilized. Do you think kind of where we're headed with this idea of social determinants of health networks as a slightly different approach to working with and engaging CBOs is what we need, and it is something that can work? And what do these networks need from the state, from the healthcare community, to really make it work?
Yeah, I think it is working. I think there are really active, successful social determinants of health networks that have been forming. Healy is one, and Public Health Solutions is another. The Health Equity Alliance is another. And we're speaking to each other all the time. We're on the phone, communicating with each other, and letting us know where are the strengths and where are the pain points, and how we're each working those out. So I do believe that it is the way in which to ensure that there's a bigger system in place, as well as the opportunity to engage in really specific project-based, models that really target certain clients and who have specific and more additional kind of needs that need to be met. So I do believe that. I'm excited. I'm encouraged that there's going to be an upfront investment in social determinants of health network. I think that is what's needed in order to engage. We're currently working closely with Unite Us as well, and looking at building out the broader system. They're helping us build the capacity to ensure that we're inputting agency information into that system in a uniform way. We're maintaining that data. The Health and Welfare Council for Healy and for Long Island, as well as being the coordination center, so that we have currently a pilot with Unite Us with our emergency food and shelter program. We're the Long Island administrator for emergency food and shelter, and so we're using Unite Us to refer to our agencies in order to connect clients with rental assistance and food cards, and so we're building out that capacity. And there's groups across the state that are doing that as well and sharing that information with each other. But I do believe that there's a lot of strength in the social determinants of health networks as they stand now. There's a lot of experience and commitment, and I think that it behooves the HEROES and those other regional entities to really lean in onto the social determinant of health networks to understand what our experience has been, and to make sure that while the HEROES really to develop the plan, the regional plan, and the interoperability plan, I hope, it's really the social determinant of health networks in many ways that are going to operationalize and actualize those plans. And so there needs to be partnership and collaboration between those in order to ensure that that plan is something that can be actualized and sustained through, hopefully, braided funding in the future.
Slightly different twist on that question for you, Chris. You're likely to be a part of a broader network. What do you need as an IPA from a social determinant of health network?
Thanks for bringing that up. Our network is relatively small. I mean, it's 15 member organizations. There are hundreds of community-based organizations in New York City, if not thousands. And so to understand whatever that entity becomes, I hope that they don't ignore networks that already exist with significant years, decades worth of expertise in the field, or the population they're trying to serve, or the services that they are providing. And so whatever that entity becomes for New York City, and it's still unclear if it's going to be one or multiple, but that there's some way of looking at what's already existing and leveraging the expertise that's there rather than building a whole new network and starting from scratch. I don't want to beat a dead horse, but with 15 organizations, we probably have 20 care management systems, EMRs. Many of these systems are used for entering data to get paid, and people don't even know, and organizations don't even know how to extract that data. And if they do extract it, it sometimes looks like hieroglyphics, and they don't have the data teams to sit down and decode it and tell a story with that data. And so oftentimes, what a social provider, the expertise they need is, what is the true cost of care? What does it cost to get someone from the street into a stable housing? Like, walk us through those steps. What is the cost of care at each stage? It takes patience, and it's a science, and there's economics. So there's some basic, financial health education. I remember sitting across an MCO, and they were, well, how long are we going to pay for food for this population? And we pay for food until they're not hungry anymore, or that it's not a 3-month intervention, it's not a 6-month, you're talking about years. And so I think without being able to say if you offer this benefit for X number of months with this model, you will get this ROI. Most SDOH providers are not that sophisticated. And so I think that would be an important part of an SDH network, to help people think through their various models of care, how to cost it, how to speak managed care. If I ever, there's legalese out there, there's, managed careys as well, around how do you speak about the work you do, the value you add. And sometimes you won't see an ROI. And I must say that it's not just about ROI, right? The quadruple aim is happier patients, happier providers are two of those components. And so value-based payment for me oftentimes focuses on the lower cost of spending and kind of ignores those other two. And so SDH networks, I think, are another way to help the quadruple aim. I think the quadruple aim is still a thing, right? I hope I'm not talking about an outdated model, but it is important. Happier patients or happier clients, whatever you call them, is still a part of the equation. And when we're talking about workforce, happier workers. And I think the SDH networks are really going to be important for that component of the HERO and listening.
Trying to tag on to that. I mean, I think what you're saying in terms of, your 15 agencies that are in the Gage Well network, they're going to sit in a larger network for New York City. And so really, there are those forming, and then there's going to be, and that are going to feed into that network, and then there's going to be the network that's going to develop those specific kind of micro networks to a degree that will have, specific projects and elements that they're aiming to do, but I think it's going to be really critical, again, convening all of those kind of micro networks to talk about how are we onboarding agencies,
Yep.
what is the common data that's being put in, how are we maintaining that data, how are we ensuring that the data is high quality, and I think it's going to be the role of the larger social determinant of health to do that piece of
Absolutely.
it, as well as to engage in that education of what you're really saying, and that's really what Healy does now, right? We meet monthly, and we have speakers that talk about, we have Emily Engel come from, New York State Department of Health and speak to us about the waiver and what's going on with it. And we've had, Laura speak to us about, and we've had Wade Norwood speak to us about ensuring that you're still really focused in on consumers and the role of that. We've had numerous speakers come to speak to the group. We just actually had our monthly July meeting yesterday, and we had Assemblywoman Salages come and speak about what's going on and how do we look at the political realities of Long Island in doing this work and what's going on in Albany. So that education piece, I think a lot of the Healy, for sure, as the Social Determinant of Health Network for Long Island, is engaging in that education. That's going to be ongoing, as well as really playing that coordinating role kind of almost like that data quarterback role,
Right.
And then also being able to do what we're doing with our emergency food and shelter program, looking at a coordination center and how are we ensuring that specific project is being done successfully.
Yeah, we went down that road of extracting the data from these three What's lucky is because we have a large HIV care management and behavioral health, they are using similar systems. And so we were like, send us your data, let's look at it. But if you look at OMH data against OASIS data against HUD, how they define homeless is different, right? And so if you're being asked to by an MCO, what does it cost to deliver care, make sure it's data informed, you're looking at 3 data sets with different payment points, different definitions. And so I do see an SDHN network kind of helping with that. But it's not inexpensive to go to a system, an EMR, and say, we need to add, not just homeless, it needs to be unhoused, it needs to be street homeless, it needs, be doubled up. Adding those extra fields can sometimes seem like a little lift, but it is expensive. And, the technology and the data, and we tried to integrate a telehealth platform at the height of COVID, and it was like $60,000 for one agency. Who has that just lying around? So I do hope that inside the waiver, that if you're going to have a successful SDHN network, again, I don't want to beat a dead horse, but there are true costs to interoperability, and no one wants to give up their system. As painful as the system might be, it, the devil that you're dealing with, but changing a system is also expensive, and the training costs. So I don't have a solution for that other than whatever sits atop the SDHN network needs to be willing or at least able to interoperate with most systems. Maybe not all. If it's a homegrown system, that might be impossible, but that's going to be an important part of the procurement process.
And really what was said to this morning also in terms of at the state level, really what you're saying before is that, every agency has systems that they're feeding into all day long, multiple systems really, because there isn't that interoperability between departments at the state level. So that has to happen also, because you could look to do interoperability regionally, but if you're not going to have it at the state level as well in terms of departments and the way we're, the reality of how we're all entering data all day long.
But it speaks to the sustainability question, which I think is what you were talking about, is, you need to know the true cost of delivering care in order for you to negotiate a contract. That's kind of the basic thing I've learned, and that I don't always have those answers, and, my network doesn't have those answers. So I'm helping try to solve that. And we do have funding from grants, from foundations over the next couple of years to kind of hone in on this piece specifically. We know certain SDOH have an ROI, medically tailored meals and financial incentives for medication adherence, or there are very clear ROIs, but how do you support a housing initiative in an SDHN or as an SDOH intervention inside a value-based payment contract? I'm not sure. Are you paying rent with that funds? Are you making sure the lights stay on? There's different ways to interpret an SDHN intervention, but it needs to have a cost associated with it. And if you don't know what those costs are and you can't point to the data to back it up, then there is no sustainability model. And so, yeah.
So in our last minute, a question from the audience. force.
Raised a really good question, which is basically like it's great that you're recognizing how important housing is, and that you're making referrals to housing, but we don't have any housing. I think the same thing is true for social determinants of health. I mean, for years we've been talking about how important it is, but Chris talked about the services agreements, value-based payment arrangements. The reality is managed care plans aren't paying for it. I think they can't really pay for it because it comes out of their administrative costs. So I think a social determinant of health loss ratio was an idea that was thrown out, I think, by Medicare a couple years ago. But as a social determinant of health network, it seems like there's a big role for you to address that issue, to get more money for medically tailored meals, to get more money for housing, to get more money for employment programs. So I just wonder if you have any, if you're doing any advocacy around that, or what advocacy you would want to be doing around that.
Yeah, I know Rob well. Thank you, Rob. I've become like a de facto development person from organizations. The number of grants I've written because I know how important it is to understand the true cost of care, and we won't do that. MCOs, they're not investors. I mean, they kind of are investors, but they're not. You need to come to them with a well thought out. So. And oftentimes he's right. If they want to, with the best intentions, an MCO wants to invest in an intervention, but if it's coming out of their administrative spend, and I sound like I know what I'm talking about, I know that's not something they want to do or that they can do, but if there's a way to have that apply to another aspect of their business, the medical loss ratio has been one. Again, I don't know fully because it's very complicated. And the MCOs that have been partnering with some of my networks and agencies, they're taking a bit of a risk, and we know that, and we thank them all the time. Thank you for dealing with this, because we need to show to the state that this kind of partnership works. But yeah, it is a tough nut to crack when you go to an MCO and say, hey, help us pay for this. We all know feeding the hungry is a good thing to do. No one's arguing that, but it's a matter of how it's funded. And I think the waiver is a great way to do that. The in lieu of service is a tool that I would like to see maybe borrowed more often, because it does then become applicable to their medical loss ratio in that regard, and it's not coming out of their administrative spend. So again, that's why these alternative payment methodologies is something we can't ignore.
Well, with that, please join me in thanking Chris and Laurie for this conversation. And we're going to take just a very quick 5-minute stretch break to set up the last session. If you need a coffee or a water or anything, there are some still over in the President's Hall. But please be back here in 3-4 minutes for our final session.